So I just wanted to, I was supposed to do this early, the first one to kind of set the stage, but unfortunately people are actually coming, it really has struck me just even sharing how people are coming from all over the world, and many people are being very brave and staying up all night for this. So
It's our pleasure. It's our pleasure to do this.
for us Americans and Canadians, or most of the Canadians, it's like, just regular day.
Can you, Professor Ann, can you, keep your webcam a little bit low so that we can see your face, because
Sure.
half of your face is,
Okay, so this is really setting the stage. So palliative care research begins with Dame Cicely Saunders, and I'm sure everybody's aware of Dame Cicely Saunders being the grandmother of hospice. In 78, she said, "It's only by asking questions and attempting to solve them that advances can be made in the practical management of advanced malignant disease." St. Christopher's Hospice, which was her hospice and is still there, was built on 3 pillars: clinical practice, education, and research. All clinical practice should be underpinned by evidence. New treatments are being proposed with unanswered questions about efficacy, dose, response, and side effects. And new services are being funded from limited resources with a pressing demand for evidence that the need exists and interventions are effective. This is a picture that I was able to get at Calgary with Dame Cicely Saunders many years ago. And she, like myself, was a doctor and a nurse, so was proud to have that picture. My other role model is Balfour Mount, and Balfour Mount is actually the grandfather of palliative care in Canada. She started hospice, he started palliative care. A man to my own heart, he has his doggies on his lap, and you'll meet my doggies later on one of the screens. But he looked at healing, from moving from suffering to a sense of well-being, and he spoke of healing being connections with self, with others, with phenomenal and with ultimate meaning. And as you'll see later, we actually stuttered. Oh no, we actually studied healing, and I'll talk about that a little bit later. So broad scope of palliative care research. Well, palliative care is not a narrow field, so it needs a lot of diverse research methods and processes. It requires an interdisciplinary team to do the research. Critical issues include clinical care, policy, funding, research priorities, ethical issues, many of which we've already heard about in the lectures today. Researchers need to be skilled in both qualitative and quantitative methods, and I do believe that in palliative care doing both, and as you will see in some of the examples of the research we've done, we've used both, you'll have a better research project. And research must drive practice. Research should be your guide, but it shouldn't handcuff you. Lots of things that we do in palliative care doesn't have a strong evidence base, but frankly, lots of things we do in medicine don't have a strong evidence base. So if there's something that appears to be working for your patients, we use it. So why do we need, and why do we do healthcare research? Well, the primary aim is to generate empirical evidence which can be used to inform practice. What is ultimately needed is a body of evidence that ensures all patients and families receive the care that is most important to their needs. It will always be critical to investigate the needs of patients and families, since the main purpose of palliative care really is to relieve suffering and help healing. And so a good way to ask what questions should I look at is, what does your healthcare system needs? What are the things you're interested in studying? And what are the bigger healthcare issues that need to be studied? So palliative care, there's a medical history that includes how different cultures approach health and well-being. And so even today, we got through the different lectures that were from all different cultures, we saw that there are differences in how we look at health and well-being. Health, well-being, and healing involves connections, relationships with each other, the animal world, the land, the sea, ancestors, and the different approaches arise from diverse ways people understand the world. One of my favorite times was when I was able to go to Israel, and this is actually visiting a Bedouin hospice. The older man who we're surrounding and whom I'm touching and examining is a hospice patient. 2 years later, my daughter was there. He was still there. The man lives in this tent-like structure on the ground. Hospice got him a bed. He didn't want a bed. This is how he's always lived. He had lots of girlfriends and lots of wives. And he loved the women from hospice coming. Really cute. This is in back of his house. He had a camel. Palliative care is a population-focused field of care. So you're going to see why palliative care is so broad. It encompasses so many different things that the research you choose to do can be in so many different things. Palliative care is individualized in that each patient is a center of the care hub, but population-focused health approaches an individual person within the context of a larger social network to include a family and community. So it's not only the patient, it's really a larger unit. Palliative care extends beyond the individual patient to recognize their culture, religion, tradition, geography, provide the context in which a patient receives care, and patients interpret their diagnosis, their symptoms, and their healing within a wide lens of relational roles and life experiences. This is a man in Tanzania, and this is actually something I saw written in a museum in the UK. I wake up in the morning, I've been sick for 10 years now. Presumably he had HIV. I wake up in the morning and drink my tea. My brother washes me. When it is warm and dry like today, I spend my days sitting outside my house under the shade my brother made. My friends pass by and tell me how their lives are going. They read the Bible together with me. At the moment, my life is rich. I have no pain. My belief in God makes me happy, and I love and have the care of my family. So again, much like the Bedouin man, this man is in a whole context of relationships, of family, friends, his relationship with God. And that's really how we need to be looking at research in palliative care. Palliative care is a bridge across ages and stages. It represents intergenerational care, families being together and interacting for the benefit of the patient. It's very helpful during transitions of care, transitions in the health status of the patient, as well as with different healthcare systems. And palliative care providers and teams can respect professional boundaries while ensuring patients feel supported in times of isolating transitions. Clearly, when people are very sick, there's lots of isolation. Another one of my favorite pictures that we've done, our team will see patients before they've had bone marrow transplants and ask them what their needs are. And when we first see them, usually the only need they have is anxiety. Once they get the transplant, they may have nausea, vomiting, oral pain, from mouth ulcers, and lots of problems along the way. But this man started with anxiety, and we actually saw him for over 2 years. He had a chronic leukemia. And he said, we asked him what he wanted. He said a magic wand and a hat. And so the day of his transplant, he was given a magic wand and hat, and we all came in with magic wands and hat. And he actually did quite well through the transplant and post-transplant until he started, until the disease took over again and he started dying. But because he knew our team for 2 years and we had this relationship with him and got him that magic wand and hat, he had a very comfortable death in our hospital and felt well cared for. Oop. Okay, palliative care as value-based care. Do unto others as you like to do unto them, the golden rule. This value and virtue spans across all ages and all cultures. The presence of palliative care has potential to carry virtue into all corners of healthcare, regardless of the age of the patient or the culture of care. And essential virtues in palliative care include personalizing dignity, maintaining hope for healing, bearing witness, honoring agency, and standing in solidarity. So we also personalize dignity, another thing we do. People experiencing life-threatening illness describe the lack of dignity in being a patient. Every patient is a whole person, not a collection of organs, but an integral entity that is at once body, mind, and soul. And so palliative care practitioners can advocate for the patient as this dignified self. I like to here tell a story of when myself and my nurse practitioner, who's on the conference with us, Karen, went to a conference, a multi-D conference on a patient who had come to our institution to get on a research protocol for her cancer that was very metastatic. She was far too sick to get on her. She was having a problem with her lungs and having a problem breathing. And so the decision was made by the primary team not to put her on the protocol. And so she wanted to go home. But before that happened, Karen and I walked into a multi-D meeting of all the doctors on the case, and everybody was looking at the organs that were going on. There was a heart doctor, a lung doctor, a hematologist, and they went back and forth about how they can help her lungs by doing windows and, inserting things like streptokinase. And then finally I said, well, what are the patient's goals? And you can hear a pin drop in the room, and all of a sudden one of the doctors said, oh, so you're looking at this from the patient point of view. And yes, that's what we do in palliative care. We look at it from the patient point of view, not from all the organs, because people are more than just a collection of organs. One of our patients, and this is really showing dignity. He's a young kid, 20 years old in our hospice unit, and he wanted a haircut. And so our barber from the institution came up and gave him a haircut. We bear witness. Most providers are trained in remedy, pathology, and fixing. Well, in palliative care, we pause from fixing and we bear witness. The most important skill is active listening. By being a listening presence, the palliative care practitioner helps elicit the patient's narrative. Bearing witness means shared stories so patients realize they are not alone in the story. And always being present, even in times of immense suffering or joy, is sacred work. Another picture of that same patient in our hospice unit with his dog. And we honor agency. Agency doesn't translate into having control. Palliative care providers help to foster agency by asking patients about their concerns, by learning what helps the patient stay strong against the challenge of illness, and by learning how the patient does not allow the illness to take charge of all of his life. Palliative care providers can help the patient rediscover his identity, and the palliative care team can help the patient and family creatively maintain a sense of personal agency to continue what matters to them. Another picture of when this young boy, Andrew Lee, was actually very healthy. We stand in solidarity. Patients feel alone. The field of palliative care is about partnerships. We work in teams, not as individuals. We offer patients, families, and staff support by standing in solidarity. And palliative care, clinical care, cannot occur without education and research. Another one of my favorite pictures, we do tea parties, and Karen, who is on the call, is also in this, my NP. And this is a lady who had widely metastatic melanoma and had lost one of her limbs, but was having a tea party and was having lots of quality of life. We maintain hope for healing. Research supports a push to move palliative care upstream. Even though there is no cure, we talk about healing. Relationships are to be recognized and honored. Palliative care providers need to ask patients what they're hoping for. When curing ends, healing goes on. Patient of ours many, many, many years ago, and we got dressed for Mardi Gras Day, and the president was going to visit us, who is actually our boss, the president of the United States, but he didn't come. And my husband commented later in the evening, it's probably because you're all dressed funny and you were a bunch of crazy people loose. So this is something that hangs in my office, the physician's daily prayer by Maimonides. May my love of the art of medicine inspire me to seek at all times to expand my knowledge and to see within each of those in need only the human being. So now I'm going to talk a little bit. I gave an overview of palliative care and really what we do, but palliative care and how we evolved in research. Just for people to know, the National Institute of Health is comprised of 23 institutes and centers. We started in the year 2000, so we're 20 years old, or a little over 20 years. We take care of the patients at the NIH Clinical Center. All patients at the NIH are in research studies, and so all care is free. It's really the way care should be. The goal of the research is cure of the disease. So we, when we started palliative care, had to focus on healing the patient, healing staff, and really focusing on back to the bedside with bedside healing. So like Dame Cicely Saunders did at St. Chris's, we really set up to do all three parts of palliative care: clinical care, education, and research. We made it clear and educated that we were not just for end-of-life care. We can see people for many years. It's not just pain management, and it's delivered in conjunction with research, and it's a combination of active and compassionate therapies focused on physical, psychological, social, and spiritual dimensions. And like the speech we heard about spiritual, in our center, spiritual and spirituality is very, very, very important. So we started the clinical by starting an interdisciplinary team, and at this point we have inpatient and outpatient services. Half our patients are under 39. We have a bereavement program where we've had over 2,000 families served. We follow them for a year. We have memorial services. We have debriefing for staff, and we have lots of integrative modalities, including mindfulness. We now also have 2 of our own hospice beds. Another tea party, and this is Hunter. And Hunter is actually going to be lecturing to us in a little while. Education, we have a fellowship program in palliative care. We have medical students, nursing students, residents, chaplains, social workers, research people, lots of people rotating with us. And then palliative care research. Well, our first research project was looking at a mixed message. Again, as I talked in the beginning, a qualitative, quantitative study of looking at palliative care patients receiving palliative care versus not receiving palliative care in the surgical oncology unit. And this was published a long time ago. We then looked at study looking at the number of outpatients receiving a spiritual assessment. And again, any of these references we can give you. We looked at our bereavement program. So remember I told you, in order to pick the research, look at what the needs are. Look at what you're interested in and what are the needs. And then we started getting into spirituality. So initially we did something smaller in terms of looking at spirituality in people who had chronic graft versus host disease, which is an illness you can get after a bone marrow transplant. But then we wanted to look at how do you define healing and developing a tool to measure psychosocial spiritual healing. That area of research started in 2009 and continued until 2018 when we finally had a tool. So as you see, something like that is a whole area of research and actually took 9 years to get from qualitative studies that we did all the way to a validated tool. So it's validated in 2018, and it's called the NIH Heals. But it took a long time. So some patients with chronic illness or life-threatening illness report positive psychosocial and spiritual change. Identifying factors that can lead to this change is known as healing and has far-reaching implications for interventions aimed at how we're improving mind, body, and spirit. So initially, we had all of us saw that there were patients that were actually what we would call healed. We did a lit review, and then we started, and this process probably took about 3 years, qualitative interviews with patients who reported positive life transformation. These interviews were done with cancer patients and with cardiac patients initially. We then got from the qualitative work, you get a lot of data. And so we got a list of 54 initial questions, and we did a pilot study of 100 patients, which was called a factor analysis. And we got down to 42 items from 54. We then took those 42 items and we did cognitive interviewing. Cognitive interviewing is actually a qualitative form of research also. So we started with qualitative, a factor analysis is quantitative. We had to go back to qualitative. At this point, we did qualitative interviewing in 3 different places with 30 patients, but then there was somebody getting her PhD in nursing, looking at a elderly African-American population in the South. So there were several studies going on with cognitive interviewing. And then most recently, we were able to do a final confirmatory factor analysis and evaluate for reliability, convergent, divergent, validity, and factor structure. And what we found is that 3 factors came to be out of the 35 questions, which included connection with higher power, with family, with religious beliefs, reflection and introspection, increased sense of gratitude, working through thoughts about dying, being surrounded by nature, and trust and acceptance. Now, this isn't all 35 questions. If anyone wants a tool, you can email me later and I can send you the tool. But, and what we're doing now is we have another study we're doing this in. We're going to try to get it from 35 to about 15 items. Oop, what happened here? Okay. So as I said, there were several other people that started looking at our tool, and this was a PhD, somebody getting her PhD in nursing who looked at it doing cognitive interviewing. There was another group that looked at our tool in a cohort of HIV infected and unaffected women in Chicago. Our work showed gender differences with the factors, and all of this is published. And then there was a correlation between the tool, resilience, mindfulness, and trauma. Currently, so lots of studies came from just saying I wanted to study healing. Lots of studies, lots of publications. The NIH Heals is currently being researched in Uganda in several, both in English and in several of their languages to get more of a different culture perspective. And we'd be more than happy to have anyone tested in your cultures. And currently in the United States, it's being studied in studies in the use of psilocybin. Psilocybin is essentially mushrooms or similar to LSD, and it is thought that it may help existential angst, people with terminal illness, with terminal anxiety. And so there are several studies looking at psilocybin, and the FDA is working with these studies and permitting our tool to be used. We then, after the 9-10 years of working on the Heals, and now we have this tool, and as I said, it's gone places like the FDA and Uganda, and there are other people studying it now. We've now started looking more at, which was another interest of mine, of well-being in healthcare providers. And so the first study we did of this kind is effective a brief mindfulness-based program on stress in healthcare providers at a U.S. biomedical institution, or our study, or our institution. And it was taking healthcare providers and doing a 5-day, 1.5-hour course of mindfulness. And it was either getting it or controls. What we found was, and this is a hard thing to see, we found decreased stress and anxiety, which was maintained, as well as increased self-care, which was maintained. And this was recently published this year in the summer in JAMA. The next study we did, which is something that has also been going on a long time, was a healing garden was made at our military hospital, Walter Reed. And we did the qualitative work and some of the quantitative questions to look at if it was better for people to walk the nature course or walk a very urban course, essentially the streets. And what we found from this was that both mindfulness and distress were decreased when walking the nature course. And this should be published in Peer J in a matter of 2-3 weeks. We just got the prints to review. Another one of my favorite tea parties, where an entire research team with OTs and PTs and researchers, and this is the man's wife. He was actually a physician who was paralyzed, but we had a tea party for him. These are my dogs, as you saw, Balfour Mounthead dogs. This is the only dog we have now, but in 36 years, we've had 4 dogs. And so this was the first one. He just died in June. He died about 9-10 years ago, and this is my daughter's dog. It's my grand dog. So 3 necessary elements is clinical care, education, and research in palliative care. You start with a vision and mission. You name the stakeholders. You form teams. You maintain focus on bedside care and teaching, but you start looking at research. The same like this, study that just came out with the simulation, or the one that we heard about COVID, 2 of them on COVID. It's, great to see that something happens and the first thing people are saying is, okay, I need to see how can I research this and what am I interested in research? And we palliate patients, family, and staff, which is why some of our research now has moved into staff palliation. Right now, we put together a project looking at wellness and healthcare providers. They're going to be getting a nature adventure plus or minus mindfulness that is on their telephones, not being there. And it's going to be for healthcare providers who are frontline on the taking care of COVID patients. So we're actually looking for a postdoc fellow, somebody less than 5 years out of their doctoral degree. And if anyone is interested, just email me. So I'll entertain questions and hope this was helpful. And looks like I closed in time.
Yeah, Professor, you are in time. So if anyone have any questions or comments, you want to add something also, you can add now or ask Professor Anne.
I have a question. Oh, sorry.
Yes, please.
Dr. Berger, what experience do you have with end-of-life palliative hospice, either one, and trauma-informed care, and how that plays a role in all of this? That's something I'm very interested in, and I have realized that there's not a lot of research or documentation about it as it relates to true end of life.
Trauma-informed, like are you talking about PTSD, or what exactly are you talking about?
So trauma-informed care being the large umbrella, PTSD, yes, falls under that. But how our past experiences, potentially past traumas from any source, how it affects where we are now, and especially at end of life.
Okay, so we haven't looked at it specifically at end of life, but a lot of the research we're doing now with the healthcare providers has to do with both trauma versus really healing. So we're looking, like with the wellness research, we have tools we have a lot of tools. So we have tools of anxiety and burnout and distress, but we also have tools of and the NIH Heals, but then we have tools of PTSD, difficulty sleeping, and all the negative side. So yes, we are looking at that. The other research that I'm involved in right now is I'm part of a whole team looking at decreasing suicide among veterans, many of them who have PTSD. In Chicago and in Illinois. It's actually called the Governor's Challenge. And so I'm on a lot of the SAMHSA calls, and I'm a big part of that team helping to put together their research outcomes, and have been doing that for the past year and a half since COVID. I've been on all their calls, which is very frequent. Well,
yes,
once a week and more. Yeah. So I don't know if you know the Governor's Challenge, but I'm involved with that, and I'm doing a lot of research with that. So yes, I mean, healing or positive life transforming changes is the opposite side of the trauma. And so looking at both are equally as important. This wellness research for healthcare providers is exactly what we're doing.
Awesome. Thank you.
Thank you for interesting and excellent presentation. And I think so that it would be really interesting to start international cooperation concerning this kind of research, and maybe do some kind of comparison, because we will also have some kind of research concerning this wellness for healthcare providers coming in the next year. I don't know whether there are similar themes or so, but it could be really nice.
Oh, I absolutely agree. And I mean, I'm more than willing to do collaborations, so just email me. I think, this is going to be the second pandemic. I mean, as we know, there are multiple healthcare providers who have killed themselves. I think the first one or two were in Italy, but then there were several in New York, an EMT, a physician, all young, and it's the second pandemic.
Yes.
And so we need to jump on this now, because suicide's already very high in healthcare providers.
Yeah, Yeah, and I think so that also this social isolation due to this pandemic also, it is very big problem also here in Finland, and all the people, they are at home and they are not allowed to go anywhere, and there are also some younger people who have mental problems or something, and they have also a lot of fears and they are very anxiety. So it would be really nice to make some kind of international research.
Yeah, I would be more than willing to do that. I was very interested in the trial. The trial itself, I thought, was very interesting, the last aid trial, because again, that was done with so many European countries. And I thought that was really cool that it was done, because in the States, we don't tend to do that much. I mean, like I said, you know, the Heals is, I'm working with somebody in Uganda, but we don't seem to do it as much as, you know, you seem to do it in Europe.
Yeah.
And I mean, Europe is smaller, but still, it's great.
Different. yeah. Thank you so much. Yeah.
So, Praveen, I had actually asked the secretary if somehow we could have everybody's emails, including all of our emails, so we could, you know, talk back and forth after this.
Yes. We will send
really
you the
nice. Thank you so
book
much.
after the conference, so that we will include all the email IDs in that, and then you can contact after this conference.
Sounds good.